Well, Pulmonary Week happens in March, and joining us this morning we have Dr. Fee. Dr. Fee, thanks for being here.
Thanks so much for having me.
Pulmonary Week, what happens during that week?
So it's actually a pulmonary rehab week, and pulmonary rehabilitation is a program that we offer here at MMC. It's a 9-week-long course. We're accredited by the National Society for that. That happened about 6 years ago that we got accreditation, which means it's governed by the highest standard for those patients with COPD, asthma, pulmonary hypertension, bronchiectasis, who need to have improvement in their functional status and learn about their disease state. So our respiratory therapists are trained, and they do about an hour and a half session with each patient twice a week for 9 weeks, go over their disease state, educate them on it, and they also do monitored exercise. And at the end of 9 weeks, we measure parameters to see if there's improvement in their functional status, and each participant has improvement. And so it's a great offering that we have here. Patients really enjoy it, and it really helps.
Well, we're going to learn more about pulmonology here in just a second with you, but before we get into all of that, tell us a little bit about yourself.
I am from Franklin originally,
Okay.
so my parents still live there. It's one of the reasons I'm back here in Meadville, to be close to family. I have a husband and 2 kids. Really enjoy being and working here.
When you had the opportunity to come back, was that something that was a priority for you?
So I trained away. I've lived away for several years and really did think about where I wanted to do my career. And coming back here and serving people that I knew growing up was part of my dream, being a doctor. And so being here at Meadville, I'm able to fulfill that, and it was wonderful.
Is there a sense of just getting to know your patients, having the time to work with your patients, and that feeling of making a difference?
Yes, yeah. The connection you can have, so pulmonology for me, I can have connection in the hospital and in the office. So when I'm doing consults for in the hospital, I can see those patients. I can develop a relationship when they're really sick in the hospital, and then carry that over to when they're in the office and make a long connection. Most of the disease states that I take care of can exacerbate, and so they can end up in the hospital. So I can kind of have that continuum of care from when they're doing well and when they have an exacerbation, and we get them well again.
So kind of walk through the stages, the levels that you may see in a patient, from young to old.
So we have asthmatics who are in their late teens. I take care of adult patients. So late teens who may see us once a year just to make sure their asthma is really well controlled. And then, asthma it's episodic. It can change over time. My plan is to be here long term and have long relationships with those patients. We have patients that are older that have COPD. It's usually more diagnosed later in life. And they need sort of a different amount of attention at times. They can exacerbate more often, so sometimes they're coming in for a sick visit, or they're coming in for a well visit to make sure we have their health maintenance up to date, inhaler checks and those kinds of things. And then we also take care of lung cancer and diagnose lung cancer. And so, those kind of office visits are sometimes a little bit harder for me too, because it's hard to talk about a diagnosis like that with patients that some of it's a brand new patient that I'm meeting for the first time, part of their workup, and unfortunately some of it's a patient that I've known for a while that on a low dose CAT scan we find something new and we have to figure out what it is.
So when you look at the scale of things, some of it's just your own habits, some of it is environment, some of it is genetics.
Yes, all three, and it's understated probably that it's not just one isolated thing. So, of course, being a pulmonologist, smoking is one of the biggest things that I talk about on a day-to-day basis. Smoking is very important to control, but it's not the only thing. Family history of diseases, not even just malignancies, but diseases, carry a strong player in whether that patient will develop that disease state, and certainly their work environment. So in pulmonology, a lot of inhalation injury, inhalation irritant, and we certainly live in an area where there's a lot of occupational hazards that we take care of patients when they get that unfortunate complication from where they work.
Yeah, and this seems to just be an interesting year with viruses and so many things out there, and some of them converging. How much of that are you dealing with?
We deal with that a lot. We get quite a few referrals for lingering cough. And this year, that's been a significant burden on patients. The viruses have caused sort of more of a reactive airways state in some patients' lungs that's more mimics asthma. And so whereas you might have gotten over your cold in a week or two, now it's hanging on for 8, 12 weeks, and that can be really frustrating. So we do a lot of education on hopefully it will get better, and then treating it a little bit like an asthma-like state for a while, and then patients usually do improve. But there's been a lot of viral impact with RSV and influenza, and then either other lesser-known viruses around the community like this fall and winter.
You kind of hinted on it, but it's not like a cookie-cutter thing. I mean, somebody with asthma, they might not know it until they're active in sports or movement, and they think they're healthy, but this pops up. There's a lot of variables in what you're diagnosing.
Correct. And there's also a lot of variables in making sure you have the correct diagnosis. So we do pulmonary function tests to help try to identify the airflow obstruction, but a lot of it's on clinical history. And so that's, as you pointed out, a lot of the time in the office is getting the history of when the symptoms started, what was going on at the time, to try to figure out and give the patient the exact diagnosis and then treatment for what's going on.
Can you run through just various treatments for some of the issues that you may see?
Sure. So we have inhaler therapy. So I joke with most of my patients, there's like 47 different inhalers out there.
Wow.
And we have to find the right one for their body. So a lot of what we deal with asthma and COPD is inhaler therapy, nebulizer therapy, and trying to get them on the one that works best for them. A lot of it goes into the severity of their illness of which inhaler is best for them. And then I also care for patients with pulmonary fibrosis, and we have medications that try to slow down the scarring. And so we do a lot of education on those medications and their side effects. And then we also have asthma has this new subset of biologic injections that patients may see on commercials. And those are for patients with more moderate to severe asthma as a diagnosis category, and do work really well. We have a lot of success with our patients in the community on those, having much less exacerbations, less time in the hospital, less time on steroids.
It's got to be interesting because turn to any channel and you're seeing a commercial for something. The basics, though, schedule an appointment to see your doctor, get that referral to you, and then have that conversation with that patient.
Right. And what's interesting is a lot of those commercials are things that patients could self-diagnose, right? So you see that, oh, that could be me. But it's important that they are going first to their primary care doctor saying, hey, could this be what's going on? And then get a referral to our office, and then we can help make sure that that's truly the clinical problem and that that would be the right solution to try.
Is that hard to sort of say, I get Dr. Google, but I need to see you, and let's have it could be this, but we want to make sure, so there's tests we can put you through and get a better idea.
Yeah, and it's a good and bad thing. Patients that educate themselves with certain modalities can be helpful, and at times it can be sitting there saying, I know that's what it said, but that's not what this is, a few times until it sinks in.
Yeah, but again, that's why you like working with patients, to actually have those conversations.
Yes.
When it comes to when you started, and we can get into that, to where we are now, how much has changed in your field?
The most changes I would say are in asthma with the new biologics, and they are game changers. Patients are doing really well. And then with lung cancer, the immunotherapy that is out there for lung cancer when I've been here 7 years, and when I was leaving fellowship to come here, lung cancer still had a pretty poor survival rate at 5 years. That's much better now, thanks to immunotherapies and earlier detection of lung cancer. So that's really encouraging to see that we can make a big impact now in that specific area.
So something like lung cancer, when should those screenings begin? Maybe if you smoke or if you don't? I mean, there's environmental circumstances.
There's environmental circumstances as well, sure. So right now the most defined guidelines are around smokers, but I do believe that it's likely to be in the next 5 to 10 years all comers, because unfortunately there is a rising amount of non-smokers with lung cancer.
Wow.
But currently the defined guideline is smokers age 50 to 80 who have at least a 20-pack year history. So, either 1 pack a day for 20 years, 2 packs a day for 10 years, that kind of thing. And that are still smoking or have quit within 15 years. So those patients qualify for the low-dose CAT scan for lung cancer screening. And that's really important that they should get them every year. We do find small nodules that need to be followed. We also can identify other pulmonary processes on those low-dose CAT scans, emphysema, and other entities that then we can address. So it's good for lung cancer screening, but it's also good to see the structure of the lung, and so it helps me in my clinical practice do more than just screen for lung cancer.
So in addition to treatment, are there things that you would recommend that a patient can do at home to, again, help to go along with treatment that may be provided?
Remaining as active as possible is one of those things that I think we take for granted in talking about the lungs, but our entire body supports our breathing. And so staying as active as you can. Another thing that seems strange, but good posture. So our posture is important, so being upright.
Did you notice everybody in the room sat up?
Is important because it helps, make sure you're having the most inspiratory capacity. And then, trying not to be around secondhand smoke, trying to quit smoking, trying to not really be around any irritants. If you're a woodworker, you're doing a lot of projects, great for you, but, try to wear masks to help you not have any of that inhalation injury.
And those are things that are recommended or said, and it's easy for somebody to say, I'll be fine. But the reality is,
it could impact, right?
Yeah.
And not just in terms of malignancy, but other types of pulmonary diseases that can cause debilitating symptoms can come from inhalation of certain things. So, it is hard to always say, I'm going to go get my mask while I'm, sanding, but, you could end up even with a fungal infection from wood that has fungus within it while you're sanding.
Wow. So at what point, what are some things that may pop up in somebody's life where you would say, okay, call your doctor and let's get this conversation started?
I think ongoing unexplained cough is important to think about. Coughing up blood at any point is a very concerning sign. Having unexplained shortness of breath that's getting worse over time is important to investigate as well. Any chest tightness with breathing is really important to investigate as well.
All right. Dr. Fee, when did you decide I want to be a doctor?
I grew up in a household where my father is a physician and my mother is a nurse. And so as an only child, dinner conversation sometimes was them talking and me listening about their day. And I brought my Cabbage Patch to my mom at age 3 saying my baby doll had a stroke. And my parents thought maybe they should back off on the conversation. So I think from an early age it was formative for me. But I ended up shadowing my dad, shadowing some other people in middle school and high school, and really seeing that medicine impacts lives in meaningful ways and that I wanted to do it.
When did you know this was the field, this was the direction you wanted to go?
That was a little more winding of a path. I liked everything when I was in medical school, going through each rotation. On each rotation, I wanted to be that specialty. So, I wanted to be an orthopedic surgeon for a little while. I wanted to be a trauma surgeon for a little while. And then I was on a rotation for trauma surgery, and I really fell in love with the critical care aspect. So that's part of my job too, is working in our ICU, taking care of patients. And I quickly realized that having that more lasting relationship could be obtained in pulmonary. So I could see them in the office, take care of them, and then see them in the hospital. So about my 4th year of medical school, I realized that that's what I wanted to do.
You mentioned family was important. What do you do to relax? What's the family like to do?
So we're pretty active and outdoorsy. We do a lot of bike riding. My parents still have a farm, so we end up helping take care of them, do some horseback riding. My children are very athletic and into sports, so I'm, giving them rides to their practices and watching their games and doing those things. And then I really like cooking. That's probably my most pastime that I use to de-stress. I'll just cook a bunch of...
Favorite meal to cook?
Chicken saltimbocca.
Oh.
It's my daughter's favorite, so.
Excellent. What's the favorite sport in the house?
Hockey right now.
Excellent.
Yeah. For them, not for me. I like basketball.
Oh, yeah. Caitlin Clark?
Yeah, she's great. I went to Duke for undergrad, so I'm a big Duke fan. So.
Okay. But there's some support there for an Iowa star, right?
Yes. Yeah.
And we have to know, did the Cabbage Patch doll survive?
It did. It recovered.
Excellent.
Fully.
Dr. Fee, we appreciate your time. Thank you so much for joining us.
Thanks.